Hi everyone, my name is Camlyn Lowe and I chose Wilson disease for my genomics presentation for Nursing 621. So what is it? Wilson disease is a rare genetic disorder that causes toxic levels of copper to build up in the liver, brain, and other organs. And this affects nearly 1 in every 30,000 people, so it's pretty rare. Most people with Wilson disease are diagnosed between the ages of 5 and 35, but it can also affect younger and older people as well. The specific gene mutation of Wilson disease is a mutation of the ATB7B gene, which is responsible for the elimination of excess copper in the body. Studies have also shown that the PRNP gene may be responsible for the delayed onset of symptoms in some patients. You'll also see this disease called copper storage disease, hepatocellular degeneration syndrome, WD, or Wilson's disease. Genetically speaking, Wilson disease is an autosomal recessive disorder, meaning both parents of the affected individual are carriers for the disease, but typically do not express the disease symptoms themselves. And if you remember from previous classes where we talked about autosomal recessive disorders, a child born to a couple who both carry the gene and don't have symptoms of the disease, the expected outcome for each pregnancy is a 25% chance that the child is born with 2 abnormal genes, a 50% chance that the child is born with 1 abnormal gene and 1 unaffected gene. So that child would be a carrier without the disease like their parents. And then there's a 25% chance that the child is born with 2 unaffected genes and will not have the disease. And these outcomes don't necessarily mean that the child will definitely be a carrier for the disease, and it also doesn't mean that they'll be severely affected if they are. Depending on which organs are affected, the clinical manifestations of Wilson disease can vary. So, copper deposits in the liver can range from symptoms of jaundice to abnormal liver function test, fatigue, lack of appetite, swelling of the feet, ascites, to cirrhosis or acute liver failure. So many of these symptoms are what you would see with hepatitis. And then copper deposits in the brain, you'll see neurological symptoms develop, which can include speech or swallowing difficulties, muscle stiffness, academic performance may decline, slurred speech, drooling, gait disturbances, or a change in handwriting due to tremors. And then if there are copper deposits in the eyes, you can develop what are called Kayser-Fleischer rings around the iris, which is in this picture here on the left. And typically that's visible with a slit lamp exam. You can see it sometimes with the naked eye, but the slit lamp exam is when you go to the ophthalmologist and they have you put your chin on that plastic rest and then your forehead against the plastic piece and they look in your eye with that bright light. It's just a sliver of light that they shine in your eye. And so that's where they can see this ring around your iris. You can also see EKG changes in patients with Wilson disease. There can be left ventricular hypertrophy, early repolarization, T-wave inversion. So lots of different arrhythmias can be seen in these patients. And then excessive copper levels can also be responsible for spontaneous abortions for patients that you know have Wilson disease, and they may just have an excess buildup of copper if they aren't being treated properly or they're not on therapy yet. You may see those. So early detection for these patients is key. Screening should be performed on all patients with a first-degree relative with Wilson disease. And this is important because the earlier you catch the disease, the sooner they can start treatment and the better hopefully their prognosis is while living with Wilson disease. And what you're going to order are liver biochemical tests, which are your liver function tests, the serum aminotransferases, your AST, your ALT. Also bilirubin, alkaline phosphatase, albumin, and prothrombin time. You're also going to order a CBC and the total copper levels, which are going to include the serum copper levels, the serum free copper, and the serum ceruloplasmin. And what you'll see in Wilson disease patients is a free copper level over 25 micrograms per deciliter, and for the serum ceruloplasmin, less than 20 micrograms per deciliter. And that's seen in 95% of Wilson disease patients. For the slit lamp exam, that's typically performed by the ophthalmologist, and that's the exam, like we mentioned, that where you put your chin on the plastic piece and bring your head forward, and they look in your eye with a biomicroscope, and they shine a thin slit of light across your eye, and they can see those rings. And typically that's seen in 50 to 60% of patients with Wilson disease. So just because they don't have that ring, if they don't, it doesn't mean that they don't have the disease. It just means that the copper may not have settled in their eyes. It may have settled more so in other places. It's also important to order a 24-hour urinary copper excretion test. The normal range for this test is 20 to 50 micrograms per deciliter. So with Wilson disease patients, 65% of them are going to have a high level of output, over 100 micrograms per deciliter. So diagnosis for Wilson disease is based on a scoring system with results of 3 or lower, kind of warranting more investigation. And that more investigation would be things such as a liver biopsy or even molecular testing for that mutation in the ATP7B gene. But the scoring is going to depend on which test you order. So different results will give different points. For example, if they do have the Kaiser-Fleischer rings around their eyes, that's 2 points. If they have neurologic symptoms, if they're mild, that's 1 point. If they're severe, that's 2 points. If they have a low ceruloplasmin, that's 1 point. If it's very low, that's 2 points. So it really doesn't take much to get a diagnosis, but you do want to get an accurate clinical picture when you're doing this testing. And genetic testing, like I said, is available for Wilson disease, but it's commonly reserved for patients with whom a diagnosis can't be determined with other testing. And mostly that's because there are so many other mutations seen with Wilson disease. So for a patient with Wilson disease, their diet from then on out is going to be a low copper diet. So you're going to limit their organ meats, such as liver. They're also going to limit chocolate, nuts, mushrooms, legumes, and shellfish, especially lobster. If you're in a rural setting and the patient is on well water, you also technically want to have their well water tested to make sure that it's below 0.2 parts per million of copper. But really purified water is best for them. They're also going to want to avoid alcohol and hepatotoxic drugs. Zinc salts are also another treatment for Wilson disease, and this blocks the copper absorption in the body, and usually the prescribed dose is 150 milligrams per day, and they break that up into 50 milligrams TID because that much zinc at one time can kind of cause some abdominal discomfort, so you may have to treat the side effects as well. The other therapy that they'll most likely have is chelation therapy. And these 3 drugs I have listed here all bind with the copper in the body, the excess copper in the body, and create a urinary excretion. So you have to be careful with the D-penicillamine with patients with penicillin allergies, but typically they do use that because it is effective. I read in one article where they typically don't use that more than a year because of the side effects on the other organs in your body. And then the ammonium drug that's listed there third is still being tested, so you have to use that with caution. And in severe cases, a liver transplant may be necessary if it's a very acute case, or if they have liver failure despite treatment, or if they have a severe or sudden onset of hepatitis, that may be necessary. And chelation therapy is lifelong, so you need to just make sure that your patients know that. So, Wilson disease is a genetic order that doesn't really have a preventable treatment other than the genetic counseling you may get before you and your partner decide to have children. But otherwise, prognosis is poor unless treatment is started early in the disease, and again, it's continued lifelong. For patients that are symptomatic, if they decide to stop their therapy or they come off of their therapy for whatever reason, typically they have between 9 months and 3 years left for life expectancy. So early onset is actually worse than late onset. And I think that was in the literature mostly because it's a longer process for them to be on the therapy. If for whatever reason they have a milder case and they just need to do the zinc salts rather than a heavy chelation therapy for the rest of their life, then usually they go on to live a fairly normal life. These are some educational resources on the internet that are available really to clinicians and patients as well. But the Wilson Disease Association website listed on the bottom is very helpful for patients because they have links for patient assistance programs if they're having trouble affording their medication or they just have questions about what their treatment might look like and what signs and symptoms to look out for. So, recommendations for Wilson disease, it really should be considered as a differential diagnosis in patients that have unexplained liver, neurologic, or psychiatric problems. And even though it's not common, it's definitely something to keep in your back pocket as far as a differential diagnosis for when your patients who come in with hepatitis like symptoms, neurological symptoms, things like that, that you can't quite link to a specific disease. And then follow up for these patients should be done at least twice a year. So you're going to want to run those tests again, the copper level test and your liver function test. And I also read an article about some new advances in molecular genetics where hopefully they want to come up with a cure for Wilson disease via gene therapy, which is a little controversial. They're still testing them in animals right now, but since Wilson disease is such a rare disease, there's not a lot of funding for things like this sometimes. So these last two slides are a list of references that I used, and like I mentioned, the Wilson Disease Association website and the Mayo Clinic website are great, easy to read resources for patients and clinicians. And the up-to-date website has a lot of great information on diagnostics and treatments for Wilson disease. So please let me know in the comments if there are any questions or you might have heard anything on here that was unclear. There's a lot of information out there, and hopefully Wilson disease is something we can kind of all keep in our mind if we ever get stumped on some of the presenting symptoms or come across a patient in practice. I hope you enjoyed my presentation. Thanks.